Good morning to all of you, and thank you, Joe. I told Joe Coslow yesterday that I was very nervous having to speak after him, and I'm afraid that that feeling hasn't changed today. So, what I'm going to do is, over the next 20 to 25 minutes, tell you how we follow these guidelines in Chennai, in India, where I work. We actually have recently taken over a second PICU in the hospital, which has a slightly larger volume than the first one. So we have a combined admission rate of about 450 to 500 per year, and a group of consultants and junior doctors that cover both hospitals. So the one on top is Apollo Hospital, which has pretty good resources, although not as good as in the Children's Hospital of Pittsburgh. And the one below is a Mehta Children's Hospital, which has a larger number of patients and more of the run-of-the-mill sepsis and malaria and dengue. Now, just a brief look at what the healthcare infrastructure is in India. We have the public sector hospitals that are a museum, a treasure trove of patients and variety and pathology and a learning experience, but they're overcrowded, long waiting lists, technology is limited. And you have the private corporate hospitals that are pretty much like a five-star hotel, and the volumes of variable costs are out of reach for most. There is a small segment which is a public-private partnership, which is funded by corporates and industries with a social responsibility. Now, spending in healthcare is much, much less than in developed countries, you can imagine. The worst part is that 82% comes as out-of-pocket payments. So patients families whose children are in ICU for a 5 or 7 day stay might end up paying their entire year's salary to fund that 1 week's stay in the ICU. The other major problem is late presentation and late referral. So early goal-directed treatment becomes a little nebulous. So high-tech resources may be limited because they're just not there or just too expensive to use. The family's willingness and ability to spend is heavily dependent on expectations of an excellent outcome. So when I talk to the family of a child with septic shock and explain what's happening, they tell me, can you guarantee 100% outcome, that they'll be 100% normal, then I'm willing to spend. And a typically late PICU presenter is likely to need much more expensive treatment, has a higher probability of dying because you need all that treatment, and they're more likely to be refractory. The possibility of all the money being invested being lost is very much a reality, and puts a higher burden on the family and a much higher degree of pressure and stress on the personnel in the ICU. So within a few days, if they feel that things are not going as well, and they sometimes pack up and bundle up the patient and just simply go away with the child. Just unhook the child from the ventilator and simply go away. So that's the way it is. And I'm sure Dr. Krishan Chugh, he works at Gangaram Hospital, which is one of the busiest hospitals in New Delhi, will agree with me that late presentations is a major problem. So when there is a problem, it means it represents a challenge to find solutions that work for our population in our unique scenario. And similarly, implementation of the ACCM Pediatric Septic Shock Guidelines needs suitable modifications so that we can try to reach the same excellent outcomes despite the late presentations and within the limitations of our setting. Whenever I look at this, I'm still referring to the 2002 guidelines. This algorithm which fits in a single slide fills me with respect and awe, simply because at least the early part is just stunning in its simplicity. It can be applied anywhere in the world, most hospitals in the world. You need to recognize that the child is sick, recognize that a child has early shock, push fluids fast, push them hard, and then titrate inotrope if they're not responding too well. And that can be done in most hospitals all over the world. And that means many, many children with septic shock can be saved by adhering to the early part of the guideline. Our problem, my problem, Dr. Chug's problem, and other people from developing countries, the problem is that they're coming late. We miss the opportunities for early resuscitation, plus the rescue tests and rescue treatments that are available to bail people out in the developed countries are simply not available. So we need to find other tools that will work for us. And I'm going to tell you something which is pretty good and work pretty well for us. So with this background of the scenario in which I work, we made minor changes in 8 respects. And the first is about the early fluid resuscitation. We've come to realize that one rate may not fit all. How we deal with apparent fluid worsening during fluid resuscitation. The anesthetic circuit with PEEP helps us to prevent hypoxemia, especially during the RSI. Using serial echoes, and this is our major weapon to guide titration of fluids and cardiac meds. Steroids, the dose and timing are a little different. Warm versus cold shock, we find that there are some gray entities in between. The goals with respect to blood pressure and perfusion are a little different for us, and how we deal with post-resuscitation fluid removal. So one by one, whatever's in the white boxes is the original ACCM guideline, and what comes in blue is where we have changed a little bit. So when we recognize early mental stasis and perfusion, that's the same. We get access, commence early antimicrobials. If there is relative bradycardia for the degree of shock, that's how we recognize that this patient may have dengue or malaria with raised ICP, and then we would go a little slower with our fluids. Fluid resuscitation rates are very rapid and very large if the blood pressure is low at presentation, and a little slower if they are in compensated shock, because they tend a little bit to have some respiratory gurgles when you push too fast. In dengue shock, the fluid rate is it's slower, and I'm going to go at length on this in my next presentation tomorrow on dengue. Now, fluid responsiveness is the same. I mean, assessing fluid with after each bolus, you assess whether shock is resolved when you cease fluids and continue to observe. Shock unresolved or better, continue up to and over 60 ml per kg, sometimes a lot more than 60 ml per kg. Or if the child is worse with new respiratory symptoms, we'd inotrope and intubate them and do an echo pretty much straight away. That's the way indications and drugs we use for intubation. Now, we know that early fluid requirements in dengue shock are lower. This was the landmark article by Bridget Wills and co. in NEGM 2005. And we've also shown the same in an article which has just come out in June this year. And my colleague in the Institute of Child Health in Chennai, she works in a busy public hospital. Their turnover of septic shock is incredible. And she's done a prospective randomized trial of 60 ml per kg of fluid over 60 minutes versus 60 ml over 30 minutes, and found that there's less respiratory complications but no change in mortality if you give the fluids a little slower. In malarial shock, we've heard Dr. Maitland tell us that albumin may be a better initial fluid than crystalloid. The other thing that we do very often is use the external jugular line, because it's usually visible and accessible even when all the other peripheral veins have collapsed. The advantage over intraosseous is that sampling is really easy. You can get all your volumes of blood that you require for early blood cultures, extravasations risk less, and it tolerates, it's somewhere between a central and a peripheral line, so the high osmolar, hypertonic solutions, infusions, dopamine, adrenaline, dextrose are tolerated much better. And once they get to an ICU, a formal change to central access is done. Now we've talked about fluid. Let's see what happens as you're pushing fluid and they start gurgling and their liver span increases. We recognize two different causes. One is true fluid overload, especially if they have underlying myocardial dysfunction. And so the treatment would be the same. You slow or stop fluids, intubate, inotrope them. The second is capillary leak syndrome into the pulmonary vasculature. And the important point here is that the circulating volume is still not corrected. They're still hypovolemic. So yes, they do need intubation, but you need to continue fluid resuscitation before, during, and after intubation. And how can you tell the difference whether you can stop fluids or continue with fluids? Do an early echo. And you can make out whether the chambers are full or the chambers are empty, and then you can proceed accordingly. The anesthetic circuit with PEEP is better than a non-rebreathing mask for preventing hypoxemia. You can see the advantage of the advantage of using this device is that it's got a PEEP valve. And so the PEEP valve improves oxygenation by recruiting alveoli and improving the FRC, especially when the fluid starts leaking and seeping into the alveoli. You can monitor the patient's airway and spontaneous breathing effort, and as it goes down, you can take over and start manually ventilating the patient. So it's got 4 advantages: improves oxygenation by recruitment, you can monitor the airway and the effort and start ventilating when hypoventilation occurs. And this has been described in adults as, more in adults, for the PEEP simply prevents atelectasis and improves hypoxemia. Okay, what happens now if the patients are fluid refractory? As most of our patients are, we begin dopamine or generally the trend is to give early adrenaline if the blood pressure is low, they are in hypotensive shock. But if the blood pressure is normal, but they're shocking with prolonged capillary refill and cold extremities, we start dobutamine pretty much straight away after fluids. Again, we do an echo and titrate, look at the look at both the right and left ventricular function, and consider noradrenaline if they are hypotensive, vasodilated, and the hearts are normal. So if they are in warm shock, fluid refractory, we document that the heart is like going on like is an overdrive. We start NORAD pretty much after the fluids. We consider stress dose steroids after the fluid and when they need pressors, and do not wait until they are much later down the track. Now, this is my favorite part, using serial echoes to guide titration. We've been doing it for the last 5 years. The first time it happened was because a hospital got a brand new echo machine, ultrasound machine, so they had nowhere to keep the old one and kept it in the ICU. And then we just tried using it when we were free, and you don't need much expertise at all. You don't need to really decipher complex cardiac anatomy. You just need to answer 3 questions when the patient is fluid refractory. Are they really fluid refractory, or have you simply not given enough fluid? Is 60 ml not enough to fill them up? How is the heart pumping? Is it poor, normal, or hyperdynamic? Is there an obstructive or obstructive pathology? So this you can make out by just eyeballing the heart. You know, if it's empty, if it's full. If it's contracting well, or if it's flabby and hypocontractile, or if there's a collection on the heart. And most of even our registrars have started doing it. I must admit, although I'm pretty enthusiastic about this, the extremes are very easy to handle when the heart's empty or the heart's full. When the heart's pumping very well or the heart's sluggish, the in-betweens are not so hard and not so easy, and then we need formal cardiology input. So extensive training and experience is certainly not required because you don't need to decipher complex cardiac anatomy. There is a lot of literature about echo performed by intensivists changing management decisions at the bedside, and has been termed as goal-directed echocardiography because the performance of such an imaging study can provide new information not accessible by physical examination, and often leads to change in therapeutic management at the bedside, and that's where you need it. So serial echoes is our trump card because we don't have all the rescue therapies available for us. This is just 2 slides about where I've got many more case scenarios where the echoes made a difference, but this is just one. A 4-year-old male with salmonella sepsis presented with cold shock, blood pressure completely unrecordable, resuscitated with 80 ml per kg fluid pretty fast. Within, I think about 30 minutes, he got 80 ml per kg fluid. He was intubated because he was almost gasping. Adrenaline infusion was started at 0.3, and he got 1 dose of hydrocortisone, all within about 40 to 45 minutes. His heart rate remained at 200 per minute. Blood pressure was 80 on 20. So I've underlined the 20 because he's cold, but he's got a white pulse pressure. His mean is low, and his CVP is 9. This is in the ICU. His chest X-ray is looking horrible, full of fluid. So the clinical impression was fluid refractory shock with likely low cardiac output, perhaps a myocardial dysfunction, and a low SVR. And we plan to give low-dose vasopressor so that we could increase the mean, add more inotropy, and of course more fluid as titrate more fluid. We got an echo done, and surprise, surprise, the cardiac chambers were virtually empty because all that 80 ml had pretty much leaked out. The left ventricle was hypercontractile. There was almost a constriction band within the chamber, because a child was already on a stiff dose of an inotrope. So the change in management was even more fluid, this time colloid. We started noradrenaline, and adrenaline was tapered and ceased. And after more filling and pressor, he didn't need the inotropy at all. His blood pressure improved, and he warmed up with the warm, bounding pulses that you'd expect for such vasodilatation. Now, steroid dose and timing. If the patients are fluid refractory, pressure dependent, we draw basal cortisol levels and give hydrocortisone at 2 milligram per kilogram, followed by similar doses over the day. We could not do an ACTH stimulation test. There were some logistic problems, so we continue if the basal cortisol level is less than 20, or we see a convincing dramatic response to the steroids. They're off. You see an ability to steadily downward titrate the cardiac meds, and they may be off in about 6 to 24 hours. Why do we do this? Why do we choose this approach? Because we assessed the basal cortisol in 12 children, and all had levels between 37 to 110 micrograms. So none had absolute adrenal insufficiency. And Dr. Lodha from All India Institute in Delhi has also documented that the stressed septic shock patient in Chennai, in Delhi, I'm not sure in other centers in India, they're already maximally stimulated at baseline. So if anything, they could have relative adrenal insufficiency. It doesn't seem at all as though they have absolute insufficiency. Warm versus cold shock. Now, this is pretty interesting. We come to this part of the algorithm where we've given fluid, dopamine, dobutamine, adrenaline. We've done a gold. With this early echo, we've recognized that the cold shock may be a little heterogeneous. This is one category where they have true cardiogenic shock, so decreased cardiac contractility with a narrow pulse pressure. The blood pressure may be low or normal. If the blood pressure is low, we start adrenaline infusion and add a vasodilator when the MAP normalizes. If the blood pressure is high, they already have an impressive increase in the systemic vascular resistance. We start with milrinone and titrate fluids at the same time. So a slow load of milrinone followed by infusion. Warm shock can be associated with contractility that's increased, normal, or decreased. Again, a smaller group of patients. We titrate noradrenaline if acidosis persists, or if the central venous sats are low, we add dobutamine. This is the entity that we've encountered, and I'll show you the breakup when I talk about the cases that we had. They present with cold shock but have a wide pulse pressure. They're cold because their stroke volume is low, and they need improved, they need their myocardium function to be improved with inotropes, and also the MAP to come up with a low dose of pressor. So there's a bit of overlap here. As their stroke volume improves, they become warm, and as their stroke volume decreases, they become cold. So it's a little bit of a blow hot, blow cold situation here. When they have low SVR, wide pulse pressure with normal or decreased contractility and fluid deficits, they can be in cold vasodilated shock or warm vasodilated shock. When you treat the cold vasodilated shock with fluids, fill them up and inotrope them, they become warm. And when the warm vasodilated shock, their stroke volume decreases, they can sometimes become cold. And again, this whole entity became clear to us because we were doing serial echoes, 15-minutely, 30-minutely, hourly. So we could see that the cold they have on their invasive arterial blood pressure showed vasodilatation. But on echo, the hearts were either empty or sluggish. And as the contractility improved, the physical examination became that of a warm shock. So treatment would be, again, fluid, pressor, and an inotrope. Now, blood pressure versus perfusion goals. The ACCM guidelines tell us to focus on SvCO2 saturations more than 70 and a MAP CVP difference. We don't titrate so much to the numbers. We do like to keep the central venous sats over 70, but rather than have MAP CVP numbers, we titrate to perfusion goals, and I'll tell you why in the next couple of slides. We keep the hematocrit above 70, above 30, the CVP high, and SvO2 over 70, and keep checking the perfusion goals. Now, this is what is in the ACCM document. And when you look at it for a 1-year-old, you need a MAP CVP difference of 60. So let's say we need a CVP highish, 8 to 10. So what kind of MAPs are you looking at for a 1-year-old? About 70. And for an adult, the targets are above 65. And again, we looked at the blood pressure centiles for Indian children, which is published early this year. And there weren't any mean arterial pressure targets. There were the systolic blood pressure and the diastolic blood pressure for 50th centile. And I worked out the MAP, which is 53. So all this means that the numbers, the goals in terms of MAP CVP are a little nebulous for our children. So we look at whatever pressure is enough to provide, to establish normal perfusion, normal capillary refill, and a venous sat of more than 70. The Surviving Sepsis campaign also cautions that even when volume resuscitation has been performed, Vasopressors may raise blood pressure at the expense of vulnerable organs. And a further concern is the increase in left ventricular work. Therapy, therefore, is targeted towards reversing clinical signs of tissue hypoperfusion, including the capillary refill, the heart rate, the mental status, and titrating MAP to whatever it takes to maintain those goals and SvCO2 of above 70. If we get to this stage, things are pretty difficult, and if they are running out of money and want to take the patient home, we don't really object. And what we try and do is try and look for unrecognized morbidities, anything that's causing the blood pressure, the shock to be refractory. And the ones I've marked in red are the ones that we've documented to be documented to have occurred both in dengue shock and septic shock. So diastolic dysfunction, this is hard for us to pick up. We need a cardiologist to pick up. If the heart is really stiff, they have early pulmonary edema with fluids, even though they're empty. Pulmonary hypertension, this occurs very early, especially the lungs. Typically, the last 2 children who had refractory shock with pulmonary hypertension, they had measles, bronchopneumonia, and their lungs were already damaged from the viral process and had a superadded staph pneumonia. So both children had very early onset of pulmonary hypertension, and when we did the echo, we found that the left side is contracting away and the right side was dilated, hypocontractile, and that was causing the problem. Abdominal compartment syndrome, as Joe's told us about earlier. So these 3 are the big ones for us. And we just looked at 25 children with septic shock over 18 months, and 13 were fluid sensitive, 12 fluid refractory. We had 2 patients with warm vasodilated hyperdynamic shock. So they got fluids, dopamine. As soon as we documented the heart was normal, we changed the dopamine to NORAD because they didn't need any further inotropy. We had 7 patients that were cold vasoconstricted with depressed cardiac function. 2 of 7 died. And we had 3 that presented with cold vasodilated shock with depressed cardiac function. They were treated with fluid, dobutamine, and noradrenaline, and 1 of these died. None of the, we checked the cortisol level only in the fluid refractory patients, and none had a level less than 28. How am I doing with fluid? With time, I think that's the last. Yeah. Fluid removal, why? Because if they have gross edema, it's much harder to ventilate them, to do anything with them. And even though they may be making 1 to 2 ml per kg per hour, they're needing so much more fluid, so the positive balances keep accumulating. And we use either furosemide infusion or peritoneal dialysis. We had pretty good success with peritoneal dialysis because when you stick the catheter in, it just allows the extra fluid to drain out initially, and then gradually move on to more hypertonic fluids. Continuous renal replacement therapy is less well tolerated than a peritoneal dialysis, much more expensive, and we've done it only very rarely. Before fluid removal, again, ultrasound echo to document that their normovolemia has been established. We don't want to tip them and push them back into shock just after we've got them out. So we document normovolemia by a combination of echo, CBP, ultrasound, all of these. You can see the distended hepatic veins, the IVC, and the pleural effusions. And this was a paper where we showed that either furosemide or peritoneal dialysis can improve outcomes of children that come late with dengue shock. So these are the points that are covered: early fluid resuscitation, dealing with apparent worsening. Remember, there are 2 causes: using serial echoes, using an anesthetic circuit with PEEP, the timing and dose of steroids, recognizing that gray entities exist between the warm and cold shock, the blood pressure versus perfusion goals, and post-resuscitation fluid removal. Oh, I had a slide with our team, and unfortunately that's gone. Okay, that's it. Thank you very much.